Here's a CT scan that was performed in a patient with history of alcohol use, and you can see that the liver here has a nodular surface contour. In addition, there's hypertrophy of the left hepatic lobe. You can see it swinging around and touching the edge of the spleen over here. And there's atrophy of the right hepatic lobe with some areas of scarring. And this patient ended up having cirrhosis, and what I wanted to show was some of the manifestations of portal hypertension. So one of the things that you can look at for portal hypertension is to evaluate the spleen. And remember, the liver was coming over, so part of this in the coronal image is actually the liver right here, but the spleen comes from here to here. And so the way we're supposed to measure the spleen size is in a craniocaudal dimension. So it's somewhat like this, and so the top to the bottom of the spleen here is measuring 16 centimeters, and so that is splenomegaly. Anything kind of greater than 13 centimeters is considered splenomegaly. The other thing you can look at for portal hypertension is the size of the portal vein, and classically anything greater than 13 millimeters is considered enlarged. In this particular case here, we're about 2 centimeters. Now the 13 millimeter cutoff has been questioned more recently, and 15 millimeters may be a better average portal vein diameter for patients. 20 is really in the upper limits, and so this patient may have some signs of portal hypertension just based off of the distension of the portal vein. When we go back to the axial image here and we look at other signs, we can see that along the greater curvature of the stomach there are a number of small vessels. Within here, these are gastric varices. There's serpiginous enhancing channels in the fundus or along the greater curvature, and they connect the short gastric vein to either the left renal vein or the azygous system. Right here we can see recanalization of the paraumbilical vein. Again, you look for a tubular serpiginous structure that is along the falciform ligament. Here's your falciform ligament right here, and you can see that the portal vein connects out here, and so this is recanalization of the paraumbilical vein. This sometimes comes to the umbilicus, and so in this particular case here you can see it approaches the umbilicus, and maybe there's a small little varix coming out here, but sometimes you can see massive varices in the umbilicus, and that's called the caput medusae sign. In this particular case here, it keeps on going down and actually goes along the inferior epigastric vein and kind of follows that, and then eventually drains into the external iliac vein. And so all of these varices are just trying to create alternative connections between what would have gone through the liver, and now they're trying to just go through the systemic circulation and go back to the IVC and enter into back to the heart. So they're trying to create other connections. Here you can also see a number of dilated veins here that are coming from the spleen. The spleen is going to be splenic hypertension here on the venous side, and you can actually see some dilated splenic veins here. And these are going along the left pericolic gutter, and eventually these ones drain into your left gonadal vein. You can see the left gonadal vein right here. It is quite plump compared to how it usually looks, and you can actually see it go into the left inguinal canal, and you have varices here. And so again, this is trying to figure out different pathways to be able to drain back into your systemic circulation. Usually splenic veins, the dilated splenic veins, will drain into your left renal vein. You'll see a nice connection between the splenic varices and the renal vein, but in this case you're having splenogonadal shunt back to the systemic circulation.